Good morning or afternoon, depending on where you may be joining from today. My name is Carrie DePria, one of the medical policy specialists for Noridian. I would like to welcome you all to the multi-jurisdictional Contractor Advisory Committee, or CAC meeting for cervical fusion. We would like to thank our CAC panel members who have taken time out of their very busy day to join our meeting to share their expertise on today's topic. We also welcome those attending in listen-only mode and sharing interest on this discussion. As mentioned, this is a multi-jurisdictional CAC meeting, meaning a group of partnering MACs are working collaboratively to potentially develop an LCD. While Noridian CMDs lead these efforts, they are joined by a group of CMDs from partnering MACs. The meeting will start with a few housekeeping items. I will then turn the meeting over to Dr. Eileen Moynihan and co-facilitator, Dr. David Somners from Novitas, who will be leading the CAC panel evidentiary discussions on behalf of all participating MACs. All lines are muted except for the CAC panelists, the meeting facilitators, and the MAC CMDs. The chat feature within the meeting is to be used for technical issues only, and questions specific to topics discussed here will not receive a response. The meeting is being recorded as required by CMS. The recording and written transcript will be available after the call on the participating MAC websites. For the panel members, we have tested your microphones and all appear to be working correctly. When not speaking, we ask you to place yourself on mute to minimize background noise that may impact the quality of the recording and attendees to hear comments. The timeframes we assigned were for ballpark allotments to gauge how the meeting is going. If the evidence is not there, it is okay to make a short statement about the evidence and the rating of it, answer the question if it can be answered, and end. You do not have to take the time allotted if it is not needed. We will conduct introductions shortly. Please indicate for the meeting record any conflicts of interest. Throughout the call, we ask that you announce yourself prior to speaking so it is clear for the audience and the record who is providing each comment. As part of this meeting, you are asked to respond to key questions on the confidence of evidence on today's topic. To ensure we are able to discuss each topic today, we have set an estimated time frame for each topic discussion. When nearing the end of that time, the facilitator will interject to communicate we are low on time. We mean no disrespect to any expert speaking at that time. This is only to ensure all topics get attention in the 3 hours today. Lastly, for those CAC members that would like to provide comments to the discussion questions, please send them to your local MACs with a completed conflict of interest form. We will conclude with a brief summary on the next steps in our LCD development process. I will now turn the meeting over to Dr. Eileen Moynihan.
Thank you, Carrie. Could you advance the slides, please? The purpose of the CAC meeting has changed. Currently, the new rules became effective January 8th, 2019. The CAC meetings are to discuss evidence and the literature on a topic. Chapter 13 of the Program Integrity Manual advises that Medicare administrative contractors shall use available evidence of general acceptance by the medical community, such as published original research in peer-reviewed medical journals, systematic reviews and meta-analyses, evidence-based consensus statements, and clinical guidelines to help form an opinion. The meetings are not held to discuss already written or proposed draft local coverage determinations as they were done in the past. CAC members' role is advisory in nature, and comments, opinions on the evidence and literature are made to assist contractor medical directors in determining if a proposed LCD should be developed and its potential content. This function supplements the Medicare administrative contractor's internal expertise and ensures an unbiased and contemporary consideration of the state-of-the-art technology and science. I'd like to take a moment to introduce the contractors and the medical directors who are working on this. As I mentioned, I am the facilitator along with Dr. David Sumners from Novitas First Coast, and I'm from Noridian. Meredith Lovelace and Neil Sandler are from CGS Administrators. Dr. Mark Jordan is from National Government Services. Dr. Judy Volkar and Jason Stroud are from Palmetto GBA, and Dr. Robert Kettler from WPS. The subject matter experts or CAC members are listed in alphabetical order. Would you please introduce yourselves by stating your name, your area of specialty, your location of work or practice, and any conflicts of interest, starting with Dr. Kellogg.
I'm Jordy Kellogg. I'm a private practice neurosurgeon in Portland, Oregon, and I do predominantly just spine surgery, at least for the last half of my career, and I have no conflicts of interest.
Thank you, Dr. Kellogg. Dr. Mendy?
Hello, I'm Kristen Mendy. I am a licensed physical therapist and a board-certified orthopedic clinical specialist. I primarily now work in the academic setting in the Doctor of Physical Therapy program at Marist College, and I have no conflicts of interest.
Thank you. Dr. Ratliff? Have you joined yet? Okay. Dr. Ratliff, are you unmuted? I'm going to just move down to Dr. Rundle. Dr. Rundle?
Hi, my name's Sean Rundle. I'm a physical therapist and an epidemiologist. I'm an associate professor in rehab medicine at the University of Washington in Seattle. I have no conflicts of interest.
Thank you. Dr. Self?
I am Shelley Self. I'm a family physician by training, but one of the core investigators with the Pacific Northwest Evidence-Based Practice Center located in Portland, Oregon, and I have no conflicts of interest.
Thank you. Dr. Shivers?
Hi, my name is Joe Shivers. I'm a physical medicine and rehabilitation physician associated with the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania, and I have no conflicts of interest.
Thank you. Dr. Slavin?
Hi, this is Konstantin Slavin. I'm a practicing neurosurgeon in the University of Illinois at Chicago. I have no relevant conflicts to today's discussion.
Thank you. Dr. Trinellis?
My name is Vincent Trainellis. I'm a practicing neurosurgeon focused on cervical spine surgery. I'm at Rush University Medical Center in Chicago. I have no conflicts.
Thank you. And I'm circling back to Dr. Ratliff. That audio pin will get you every time. Is he still unable to speak? Okay. Okay. Well, Dr. Ratliff is a professor of neurosurgery, and I'm going to just say he's at Stanford University. He has a lot of titles here. He's program director of the Department of Quality, and he does have a few conflicts of interest that we'll circle back to when he is answering a question, because we're still having trouble getting him on audio. So I'm going to move on to a report from the Agency of Healthcare Research and Quality. Dr. Shelley Self is principal investigator of the current evidence-based practice center report that you're about to hear about. Please hold all your questions until the end of her presentation. Dr. Self has already incorporated some questions that I have given her from the medical directors into her talk, and other questions can be asked at the end, but they should focus on the work done on this report. Anyone who's not speaking, please mute your. Thank you. Dr. Zell?
Yes. So next slide. So I'm Shelley Self, and I've been doing systematic reviews on a variety of topics for over 13 years with the Pacific Northwest Evidence-Based Practice Center. Next slide. So some guidelines Eileen just talked about. Please hold your questions till the end and limit your questions to the material presented. I want to point out too that this is a high-level summary only because of time constraints, and that individual study details and outcome details will be in the evidence reports, but are not included in this presentation. Next slide. Here's our review team. We do include an individual who is a neurosurgeon or spine surgeon, pain individuals, as well as physical therapy, statisticians, and epidemiologists. Next slide. None of us on our team have any conflicts of interest. Next slide. So this report was based on research that we did at the EPC. It was paid for by AHRQ, the Agency for Healthcare Research and Quality, but the findings are and conclusions are those of the authors, it may not represent necessarily the views of AHRQ. Next slide. So the purpose of the review was looking primarily at treatments for cervical degenerative disease. This review was nominated by the Congress of Neurological Surgeons, and they published prior guidelines on the management of CDD in 2009. And it is the hope that our review will provide the evidence base for updated guidelines from CNS or others. And the final report will be posted in the coming months. Next slide. So we had 13 key questions, and I'm not going to go over them all here or read them all here because I'm going to talk about them as we get to the results of these key questions. Next slide. Next slide. Next slide. They're mostly here for reference. Next slide. So part of our methods, we did look at multiple databases, Embase, Cochrane, and Medline. We looked at studies published since 2006. That's because that was the search date in for the prior guidelines, and this is for operative studies only. The prior guidelines did not address non-operative approaches to CDD, so we went back to 1980 for those studies. We did do dual review of abstract and full text level and assessed each included study for risk of bias or their study quality. We also assessed for each key question the body of evidence for that key question using the domains that are listed there. And just a comment about what strength of evidence for us means. And essentially the strength of evidence reflects our confidence in the truth of the findings. So low strength evidence implies that we have low confidence that future research will not change the findings. Strength of evidence could also be rated moderate, high, or in some cases insufficient. We use insufficient when we have some evidence, but too little evidence to really draw any conclusions, or the evidence is too conflicting to draw a conclusion. Next slide. So we reviewed almost 4,500 abstracts, and of those we pulled about 1,500 full text to review. We wound up including 106 studies. The key question with the most evidence was for key question 8, which looked at the comparison of arthroplasty versus ACDF. And for that key question, we had 33 studies. And then again, the draft and then the final report coming up will have all the specifics. Next slide. So the first key question looked at individuals where you have you do an MRI and you have this incidental finding of spinal cord compression, but the patient essentially has no myelopathy. Should the patient go to surgery, or should there be other ways to manage the patient? Either no surgery or some other conservative treatment like exercise or a collar or physical therapy. Unfortunately, though, no studies addressed this question in that population. Next slide. So as key question 2 is very similar, only in this case, you do have individuals who have either mild, anywhere from mild to severe myelopathy. Again, should they go to surgery or should they have some other treatment? We did find a little bit of evidence on collar medication and bed rest, but not enough to be able to say whether surgery or no surgery would be preferred. Next slide. The next question is looking at all comers, radiculopathy and myelopathy patients. What's the evidence in surgery, the benefits and harms of surgery versus no surgery? We did find a little bit of evidence for physiotherapy and a collar, but not enough to make to draw a conclusion from. Next slide. So the next slide is looking at surgery versus the same surgery plus an add-on treatment. For instance, collar, electromagnetic stimulation, or exercise. We didn't care if the treatment was pre-op or post-op. However, all we were able to find were studies that looked at post-op treatment. The first comparison of ACDF versus ACDF plus a collar, a little bit of evidence, but not enough to say anything. ACDF versus ACDF plus electromagnetic stimulation. We did find a small effect that favors the use of adding on electromagnetic stimulation when the outcome is fusion. So slightly more likely to be fused if you use electromagnetic stimulation, but again, not a great body of evidence. So our strength of the evidence is low, meaning we have low confidence that future research will not affect that conclusion. With regards to pain and function, with the use of electromagnetic stimulation in addition to ACDF, we had similar findings regardless of whether or not you used electromagnetic stimulation or not, again, but low confidence in those findings. Looking at laminoplasty versus laminoplasty plus a collar, similar findings on pain and function, but again, low confidence for those findings. For laminoplasty versus laminoplasty plus exercise, we felt we had insufficient evidence to draw conclusions in that comparison. Next slide. So the next one is looking at anterior versus posterior surgery at 1 to 2 levels. In this case, anterior surgery for this group of studies was anterior cervical foraminotomy, anterior cervical decompression without fusion, and ACDF. And in all comparisons, the posterior surgery was posterior cervical foraminotomy. Basically, the results on arm pain, reoperation rate, neck pain, neurologic deficits, they were similar, but low strength evidence or low confidence in those findings. I do want to point out there is a concern for selection bias in making this anterior versus posterior comparison, because often different people receive, could you go back, please? So often different people receive the 2 different types of surgery. For instance, posterior surgery may be more likely to be found in older individuals with higher comorbidities. In order to help mitigate the selection bias there, we did focus on RCTs. However, most of the evidence was not good quality. And we looked at non-randomized studies, but we required that the study control for at least one potential confounder. For instance, something like age or comorbidities going in. That meant that we did not include a fair amount of studies because they did not control for anything. And in some cases concluded that, for instance, anterior surgery is better because the outcomes are better, but they were really operating on 2 different populations. So those studies are not included. Next slide. So for key question 6, it's the same question, only we're looking at greater than or equal to 3-level disease. We have low confidence that there are similar results with regards to neck pain, function, reoperation rates, mortality, and dysphagia. There was a moderate to large effect favoring anterior surgery with regards to serious adverse events. So you had fewer serious adverse events with anterior surgery. Same with neurologic adverse events. And our confidence is still low. And the same concern for selection bias is key question 5, and we handled it the same way. Next slide. Key question 7 is looking at patients with myelopathy. What are the benefits and harms of laminoplasty versus laminectomy and fusion? A little bit stronger evidence here we have moderate confidence that function and reoperation rates are similar with the two procedures in that population. There was a moderate to large effect favoring laminoplasty with regards to adverse events, but our confidence in that finding is low. Next slide. So key question 8 is the key question that we had the most evidence in. It was looking at the comparison of cervical arthroplasty versus ACDF. We had moderate confidence, moderate strength evidence that pain and function are similar with regards to those two procedures. There was a moderate to large effect favoring arthroplasty, as in fewer reoperation rates with arthroplasty at one level. Strength of the evidence is high there, but at 2 levels it drops to low. There is a concern here that in ACDF, reoperation rates at the index level may be affected by the need to remove a plate in adjacent segment disease. Unfortunately, a lot of the studies that reported reoperation rates did not report the indication for the reoperation rates. And when we were able to, we parsed that out, but oftentimes we were not able to. So that is a concern with this body of evidence. With regards to serious adverse events, there was a small effect that favored arthroplasty. We have low confidence in that, though. Similar effects on neurologic adverse events. Also wanted to point out that many of these studies were funded by industry, and they were written by authors with ties to industry, which may have introduced some bias also. Next slide. So key question 9 had several parts. The first part had the most evidence, and that's looking at a standalone cage for ACDF versus a plate and cage. Essentially, we found the results to be quite similar between the two approaches. In fusion, we were moderately confident that the fusion rates are similar with neck pain, function, quality of life, and adjacent level ossification. We weren't quite as confident that those are similar. Next slide. Still key question 9, we looked at, again, also in ACDF, we looked at PEEK cages versus titanium or titanium coated cages. Essentially found a small benefit favoring the PEEK cage on fusion and function, but there wasn't really a lot of evidence there. So we have low confidence that that would stand up in the face of additional research. Key question, or next slide rather. And then we looked at, in ACDF, the use of autograft or allograft or other osteogenic materials. Unfortunately, there was pretty much only one study that looked at each of these comparisons, so not a lot of evidence for any given comparison. The findings that we were able to say is that there was a large increase in adverse events if you use BMP2. So it favored the non-use of BMP2. But due to the quality of the studies of that evidence, our strength of the evidence, we rated as low. Next slide. So for key question 10, in the case of pseudoarthrosis after anterior fusion surgery, should you use a posterior approach versus revision anterior arthrodesis? What are the benefits and harms for each of those approaches? Unfortunately, no studies address that. Next slide. Key question 11, in the instance of myelopathy, what's the prognostic utility of an MRI for neurologic recovery? There was a moderate benefit if there was no signal, less sharp signal or decreased signal intensity, that you could predict neurologic recovery, but the strength of the evidence for that was low given the number and quality of the studies. The other issue with this body of evidence is that the question was in myelopathy. Unfortunately, the studies included radiculopathy only patients, or in some cases did not specify patient symptoms. So not the best evidence base for that question, and we rated it low. Next slide. For key question 12, can use imaging to predict pseudoarthrosis. Pseudoarthrosis basically found yes, somewhat with dynamic radiography, either in an asymptomatic or asymptomatic population, but low confidence in that that would hold up with additional research. Next slide. The next slide looks at intraoperative neuromonitoring versus no intraoperative neuromonitoring. With regards to neurologic complications, they had similar findings, but we rated that low strength of evidence or low confidence that would hold up with additional studies. One of the issues with this literature is that it's based on 2 database studies where neuromonitoring or no neuromonitoring is determined by billing codes, and not all the time is when neuromonitoring is used is it billed for. So we think that the utilization would have been the preferred method of determining who got neuromonitoring and who did not. And because billing codes were used, that may actually significantly undercount intraoperative neuromonitoring, and that could potentially bias those results. Additionally, the studies were limited to ACDF and no other surgical approaches, so we rated that low strength. Next slide. So overall, the highlights for the strengths and limitations are that we use the best evidence approach, relying on RCTs when possible, and only looking at non-randomized studies that controlled for at least one potential confounder for efficacy. For limitations, there was often low quality evidence, too little evidence, or no evidence for some of the key questions, and we did limit studies to the English language. Next slide. So our conclusions were that there were few differences in benefits between compared surgical approaches and techniques. There were some differences in frequency of adverse events. However, we are limited by what is reported in the studies, and there is concern for bias in much of this evidence. Next slide. So this is just a link for your reference about where to go when the final report comes out. Next slide. So some of the questions that you had, were any studies focused on the typical Medicare beneficiary age 65 and older? So when you look at each of the key questions, the mean age of the participants by studies, the mean age was in the 40s, 50s, or 60s. When you're looking at key questions as a whole, for no key question was the average study mean age greater than or equal to 65. And that's looking at the body of evidence. But now if you look down at individual studies, we found 11 studies with a mean age greater than 60, 4 with a mean age greater than 65, and 2 studies with a mean age greater than 70. Additionally, there were numerous other studies that included individuals with ages greater than or equal to 65. Unfortunately, for these studies that had a broad range of ages enrolled, they did not report the results by participant age. So I think the Medicare beneficiaries, that population are in, are in the body of evidence, but not always parsed out as to the specific results for those individuals, except perhaps in those studies that pretty much only enrolled older folks. Next slide. So were there any studies that focused on diversity and not generally? In fact, very few studies reported race or ethnicity even. Some studies did report the percentage of their population enrolled who smoked, used alcohol, or had diabetes, but typically, they did not report the results by these patient characteristics. So diversity focus was not found in the literature. Next slide. And did the Medicare age group tolerate general anesthesia, and was mental status permanently affected? So these were not reported. I did go back and look at specifically in those studies that enrolled an older population, and none of them reported issues with general anesthesia or mental status changes. Sometimes all we have for those studies are a statement saying there were no serious adverse events, or there were no complications noted, or they may have listed some complications but never mentioned anesthesia or mental status changes. Next slide. So I open it up to your comments or questions.
Are there any questions from the contractor medical directors or from the panelists for Dr. Self? Okay, then thank you very much. We are going to move on to the discussion questions that we have. I just want to point out on the final agenda that question 6 has been moved to the end to allow more time for discussion, and that there have been some bibliography changes to the original bibliography that you were sent. At this time, try to remember to say your name before you give a response, and I am going to turn this over to my co-facilitator, Dr. Sumners.
Thank you, Dr. Moynihan. I assume everyone can hear me. We're now going to go through the questions that were developed for the cervical fusion subject matter experts. Certainly appreciate everyone that's here today. Again, we ask that you base your opinion on the clinical literature and certainly with the consideration of the quality of evidence to support your answer. Question number 1. What is the evidence and/or society guidelines concerning the provision of non-surgical or conservative care prior to proceeding with cervical spine fusion surgery? And there are 2 subparts that I will interject as well. Dr. Rundle and Dr. Mendy, we would ask you to comment on these. We have about 10 minutes to do that, and as I said, we'll talk about A and B, or if you want to raise those yourself, you certainly can. Please go ahead. Thank you.
Sure, I can start. This is Sean Rundle. So generally, just in the broad topic, I think there's a lot of uncertainty in non-surgical care for conditions before proceeding to spine fusion surgery, specifically cervical radiculopathy and cervical myelopathy. Starting with cervical myelopathy, there's really a lot of uncertainty. I think there's minimal to 1 clinical trial out there, so the evidence really is low quality or inconclusive. And the other literature out there besides that trial that I could see are basically observational studies comparing non-surgical interventions to surgical interventions or fusion for people with myelopathy. And there's a lot of variability in who's selected as far as severity of myelopathy too. So I think regarding non-surgical care for people with myelopathy, it's fairly inconclusive. Moving on to think about cervical radiculopathy, there's a little bit more evidence, but a lot of the evidence I'd say is low strength of evidence or low certainty. So there is some evidence that sort of multimodal rehab approaches, involving neck specific exercises, education, and maybe some cognitive behavioral components for people with more chronic cervical radiculopathy may provide some benefits for people, but that same body evidence doesn't really suggest that that multimodal intervention provides greater benefit than surgery or fusion for people with cervical radiculopathy, and it does not provide greater benefits than epidural steroid injections. But again, that's based on very few trials and probably low strength of evidence. You look at the physical therapy clinical practice guidelines, and there's some, again, that's probably a low quality of evidence or low strength of evidence that interventions such as strengthening and stretching exercises and manual therapies may provide benefit for people with cervical radiculopathy, or they term it cervical neck pain with radiating symptoms into the arm. You think about just neck pain in general, maybe not specific to cervical radiculopathy or myelopathy. The evidence comes a little bit better, and they have a sort of a review of guidelines, which I think is included in the reference section. And there's moderate strength evidence that for general neck pain, interventions such as exercise and manual therapy combined with exercise provide benefit for people. And then there's a little bit weaker evidence, so probably low or very low strength of evidence that things like reassurance, education, recommendations to remain active, use of various types of analgesics, some psychological interventions, and multidisciplinary care may provide benefit for people as well. Generally, my take on the whole non-surgical interventions for people with these conditions is that a lot of the literature is not only limited by the lack of quantity and then even quality, but there's just of what's there. There's a lot of variability in the study samples. For radiculopathy, for example, a lot of times the literature is a mix of people with a mix of ages, but also a mix of people with radiculopathy due to disc herniations, combined with people with radiculopathy due to stenosis from degenerative changes. And similarly with myelopathy, there's often a mix of severity, or how they grade severity, determine severity is really variable. So there's a lot of uncertainty there. A lot of the interventions, non-surgical interventions, tend to be multimodal, so it's really hard to tease out what specific non-surgical interventions provide benefit over other non-surgical interventions, because so often they're comparing multimodal interventions to some comparator, and there's really not a lot of standardization in comparators, outcomes used, follow-up times that they're looking at in general. I can address parts A and B briefly too. Part A, there's really not a lot of strong evidence to suggest that a minimum time frame is recommended, or minimum number of visits. So I'd say that's pretty conclusive. And also, when you're looking at prognosis for Part B, percentage of patients that resolve without surgery. I think for cervical radiculopathy, there's a little bit more evidence suggesting that a lot of people have a fairly favorable prognosis. Some reviews suggest somewhere between 75 and 90% see improvement in symptoms, especially over the first 6 weeks. But even with that, a sizable portion of people still have persistent symptoms or have recurrent symptoms. The studies I looked at, that generally ranges from low 20% to low 30%. People have persistent or recurrent symptoms after cervical radiculopathy. And then cervical myelopathy, the prognosis, especially without surgery, is much less clear. Literature is very old and low quality, and the general sense is that it's maybe a progressive condition, but maybe a slowly progressing condition. But to be able to put any percentage on it, I think is you can't conclusively say that. So that's my summary. Thank you.
Dr. Mendy, do you have some comments?
Yes, this is Kristen Mendy. I think Dr. Rundle actually summarized it pretty nicely. For the most part, it really is, there's no strong evidence necessarily. It seems to be there's a relatively low level of evidence out there concerning conservative care, more specifically looking at like physical therapy and some of the other conservative options. And one of the limitations in the studies that are out there, as was just mentioned, is that variability in the interventions. They range from just putting someone into a cervical collar to doing several hours of traction a day. So it's very hard to really get conclusive evidence when the interventions that are being assessed and kind of all pulled together are so variable. So kind of looking into both parts A and B, similar to what was just said, there's really so much variability with respect to what you might see in the evidence to support a specific time frame, and even in looking at some of the systematic reviews that were on the reference list, some of them don't even indicate the length of time for the studies that were examined for the patients to have received the conservative therapy. Some ranged from a few weeks up to 3 months, so it's just quite variable. And then the percentage of patient symptoms resolve, again, just the numbers are kind of all over the place, so it would be hard to have a definitive answer there. It does seem to be also, as was mentioned, with a radiculopathy versus a myelopathy, a little bit better outcomes with conservative care. Some of the systematic reviews, I think it was the first article, the Failings article, was looking pretty specifically at cervical myelopathy, and they had pretty strong evidence to support surgery for moderate and severe myelopathy. And then there was just really a lack of evidence, and the evidence that was available was not the best quality evidence, discussing conservative care versus surgery for more mild levels of myelopathy. What is interesting is, despite kind of the lack of evidence, several of the studies that were on that reference list that pertain to this question did still recommend, whether it be related to radiculopathy or a mild myelopathy, a trial of conservative care before moving into surgery, but not necessarily a recommendation backed by the evidence. My thought is they were thinking it's obviously, they weren't necessarily at risk of doing harm by doing a conservative trial before moving on to surgery. So they thought it might be warranted in those cases to see if it might make some improvement and then go from there. But otherwise, I think Dr. Rundell summarized it really nicely. So.
Okay, thank you both. Appreciate that. With that, I think we've dealt with A and B as well. I think we'll move on to question 2. You sort of hit on it a little bit, but I'd like a little more discussion. And it reads, is there evidence of society guidance regarding the use of alternative procedural treatment modalities prior to the use of cervical fusion, such as laminoplasty, arthroplasty, foraminotomy, etc.? And we'd ask Dr. Shivers and then Dr. Mendy to also comment about this too, please.
Dr. Mendy, you're on a roll. Do you want to go first? Or I'm happy to as well.
I can. Sorry, just to state my name again for the recording, Dr. Kristen Mendy. So I do think that Dr. Shivers might have a little bit more specific to add to this from the medical standpoint, but I can kind of re-summarize again from the physical therapy piece of it, again, there's not really any strong evidence regarding the use of that level of conservative care prior to fusion, but it does seem to be the studies that do exist that seem to be in favor of it are relatively low quality, but there seems to be consensus from the authors regardless that if it is a condition that, I hate to use the term more mild because to the patient it probably doesn't seem mild, but something that is a radiculopathy or maybe a mild myelopathy, it might be worth a trial of more conservative care prior to moving on to surgical intervention. And interestingly, one of the studies that compared surgery to conservative care, the individuals that were classified into the conservative care were given the option after the trial ended to go ahead and proceed to surgery, and actually a relatively low number of them opted to actually undergo surgery. So again, not strong evidence, relatively low numbers, but the authors felt that that might suggest that while the relief received from physical therapy was not as significant as that from surgery, perhaps it was functionally enough to satisfy the patients to decide to forego surgery. And I will hand it over to Dr. Shivers for the rest.
Thank you very much, Dr. Mendy. Well said. I, again, am Joe Shivers. I do not have any conflicts of interest. So the short answer is as Dr. Mendy said, nothing great. The 20th reference by Bono and colleagues made reference to epidural steroid injections as having some level of weak evidence suggesting that it maybe provides relief for about 60% of patients based on their systematic review, and that maybe the 25% of people who would otherwise have surgical indications for cervical radiculopathy are able to get relief. I should have signposted that a little bit better and made it clear that I'm referring specifically to cervical radiculopathy there, that epidural steroid injections maybe help with kind of buying people time for cervical radiculopathy to get better on its own. From that same paper by Bono and colleagues, the 20th reference on the list, they say on the bottom of page 66, quote, "It is likely that for most patients with cervical radiculopathy from degenerative disorders, signs and symptoms will be self-limited and will resolve spontaneously over a variable length of time without specific treatment." And so for cervical radiculopathy, there's not nearly as much data on cervical radiculopathy relative to lumbar radiculopathy, but the data on lumbar radiculopathy are pretty favorable in that the vast majority of people will have good motor recovery and significant improvement in pain over the course of weeks to months. And so I think of conservative care in cervical radiculopathy largely as just sort of buying time for the natural history to take effect, the natural history usually being favorable, and then that part of conservative care is monitoring to make sure that people don't have progressive neurological deficit or pain that is just so intractable that that they need the surgery from the perspective of pain relief. For cervical myelopathy, I do not understand epidural steroid injections or really any other sort of procedural treatment to be indicated, and tend to think that the role of conservative management is simply to monitor, as Dr. Rundle said, the course of an anticipated decline in myelopathy is not necessarily clear for the population as a whole, let alone for an individual patient. And so I think of the role of conservative care in myelopathy again as essentially being watchful waiting, with the only real treatment option being surgery.
Okay, thank you very much for both of you, excellent summary. I think question 3 we've talked a little bit about, but Dr. Rundle, I would just ask if you have any other comments in this regard. Are there circumstances where conservative treatment may not be appropriate? Again, I know Dr. Shivers just mentioned some of those, but perhaps you could opine on some other instances as well.
Yeah, certainly. So this is Sean Rundle. I think traditionally, I think people coming in with cervical conditions, especially if they have symptoms consistent with radiculopathy or myelopathy, we look for red flags. So we're looking for people that may have a fracture or trauma that resulted in a fracture. You're looking for signs and symptoms consistent with malignancy or spinal metastases to the spine, infections, and then specific to myelopathy, I guess we're also not just looking, do they potentially have myelopathy, but do they have pretty significant and concerning neurological impairments where they may be having more rapid deterioration and need more urgent surgery. So things basically spinal cord injury or a bit more significant spinal cord compression. For those scenarios, or we traditionally think that either additional investigation needs to be done before conservative care could be decided if it was appropriate or not. Things such as MRIs if they haven't been done, or other medical evaluation, or they may be more appropriate for surgery based on those presence of those conditions. My impression is a lot of that evidence, although it's fairly standard clinical practice, there is not a lot of strong evidence in clinical trials. It's more based on awareness of the potential risks and trying to minimize those risks and consensus around that.
Okay, excellent. Thank you for that summary as well, Dr. Rundle. We'll move on then to the next question, number 4. Dr. Shivers, this will be your question. What is the evidence and/or society guidelines concerning factors likely to influence surgical outcomes? And here we're kind of, for example, behavioral risk factors such as smoking, opioid use, things like that. If you would care to comment on that, thank you.
Sure, thank you. This is Joe Shivers again. So the two papers in the bibliography that most spoke to these questions, I thought were 10 and 11, the Harrop and Kang. I'll talk about the number 8, the Enquist one, a bit as well. In the Harrop study, they talked about hemoglobin A1C obviously as a continuous variable that reflects diabetes control. The worse diabetes control tends to pose a higher risk of adverse outcomes. They noted 7.5% as the A1C, where there's sort of an inflection point in that curve, but it didn't sound like that was a hard and fast or a cutoff so much as if they had to pick a cutoff, that was the one where it made the most sense. BMI seems more relevant from the perspective of risk of deep tissue infection, wound infection in posterior surgery than anterior surgery in the Harrop paper. But then Kang and colleagues cited a study in which BMI was associated with a higher overall rate of perioperative complications. Smoking seems to be a very well accepted risk factor for pseudoarthrosis, as referenced in both the Harrop and Kang papers. I was surprised to learn in the course of this review that there is not great evidence that smoking cessation is of any benefit. The surgeons that I work with, or that I know of, I guess I don't work with surgeons so much as refer to them sometimes, the surgeons whose notes I see seem to insist on smoking cessation anyway before fusion surgeries that are elective. In terms of the Enquist paper, which I guess there were 2 Enquist papers, references 8 and 9. There were a couple aspects of them that made me skeptical of their utility. One was the relatively small sample size. One was the fairly loose definition of radiculopathy, where people basically just had to have arm pain and sort of neurofibrotic stenosis somewhere on the radiology, which sort of everyone does. But they didn't necessarily need to have kind of correlating weakness or sensory deficits, which I think raises the question on the part of the reader of, what exactly these people did have. And then there were a couple other aspects of their conclusions that sort of went against the conventional wisdom, one of them being that anxiety was a positive prognostic factor for surgical outcomes, and another was that neck pain responded more to the cervical fusion than arm pain did. So I, by contrast, was sort of trained to think that anxiety and depression tend to be negative prognostic factors. Just looking last night, I found a paper by Strom, STRO with a diagonal line through it, and Bajaram and Nielsen and colleagues from the Spine Journal in 2018 that sort of spoke to the adverse prognostic effects of anxiety and depression prior to surgery, and talked a bit about how information and expectation management can sort of mitigate those risks a bit. I think that there's a much larger body of literature there, and I'm sorry not to be more specifically familiar with it, but sort of on a related note, I think also from my training and clinical experience that patients' understanding of what they're getting into is important. And so if the purpose of the surgery is really to prevent deterioration of mild myelopathic symptoms and not to address neck pain, but the patient thinks that the purpose of the surgery is to address neck pain, and then their neck pain doesn't get better after the surgery, that bodes ill for their satisfaction. And so I think that expectation management and stress management and helping people to make decisions about their care from a place of rational analysis rather than desperation is an important point of conservative care, whether it's explicitly preoperative or sort of alternative to operation, or helping people to make that decision. With regard to opiate use, that didn't seem to be addressed head on in the references that were highlighted for this question. And again, I just found a couple. I think there's a larger body of literature on this in lumbar surgery, but for cervical, I found a paper called "Preoperative Opiate Use Leads to Increased Postoperative Opiate Use and Readmissions After Anterior Cervical Discectomy and Fusion" by Chung, C-H-U-N-G, and colleagues, that was published in the Journal of Spine Surgery in 2022. So this was a single center retrospective cohort study from Loma Linda with 198 patients, 102 of whom were opiate naive, 66 with opiates less than 6 months, and 30 with opiates more than 6 months. And the folks who were on opiates for longer periods had a much higher readmission rate in the 90 to 365 day post-op period. And they also had a much higher rate of opiate use over that same period, suggesting A, that surgery doesn't necessarily help people wean off opiates, and B, that for people who have been on opiates for more than 6 months, that they might do worse post-operatively. And then there was another recent paper by Samuel and colleagues in the journal that's just called Spine from 2021, which was association of duration of preoperative opiate use with reoperation after 1-level anterior cervical discectomy and fusion in non-myelopathic patients. And so this was an analysis of a private insurance database. They had 445 patients undergoing single-level ACDF. The patients were not myelopathic. 2/3 of them were taking opiate meds before surgery. For the 1/3 of patients who were opiate naive, their 5-year reoperation rate was 4.7%. And then for patients who were on opiates chronically beforehand, the reoperation rate at 5 years ranged from 15% to 25%, depending on the opiate agent in question. So seeing surgeons' notes and occasionally talking to them about this stuff, or shadowing during my fellowship year, it seemed like surgeons really try to wean people down who are on high opiate use, which is sort of a separate question aside from the duration. But it seems like perioperative pain control tends to be harder when people are already on a very high chronic opiate load. So that doesn't necessarily change the decision of whether to operate, but sort of influences the decisions around when, I think.
Okay, thank you, Dr. Shivers. Thank you also for summarizing those opioid studies. We'll move on to the next question then. What criteria do you consider before offering cervical fusion surgery? Looks like you're up again, Dr. Shivers. There are subparts of this as well, and I'll read those for our edification. Part A, what degree of pain or functional disability are you looking at, and how do you measure that? And then what sort of radiographic imaging would be consistent and that you would want, or the literature would support to be consistent with a surgical candidate? Thank you.
Sure, thank you. To my surgical colleagues on the call, I want to make it clear that I am not so hubristic as to presume to offer cervical fusion, since I do not do surgery. But I certainly do sometimes recommend my patients to speak with surgeons and try to facilitate a warm handoff, and can certainly speak to my decision making around that. So the first question for me is, do they have a diagnosis and clinical presentation that's sort of amenable to surgery? And I think we've all, so far, all of us non-operative folks have been speaking mainly about radiculopathy and myelopathy. I know I'm a non-operative not really particularly interventional physical medicine and rehabilitation physician, and I'm mostly seeing people in chronic pain. So it is vanishingly rare that I see traumatic instability or multi-level cervical autofusion, like in diffuse idiopathic skeletal hyperostosis or ankylosing spondylitis or malignancy. And so once again, I'm really kind of within this answer sticking with cervical myelopathy, cervical radiculopathy, and that what we're calling central spinal stenosis, this sort of incidental radiological note made of spinal cord compression without any symptoms or signs of that as yet. So for myelopathy, you know, clinically myelopathy, just to sort of frame how I think of that clinical presentation, that's symptomatic, usually, you know, some level of symptoms in terms of fine motor deficit, or even if it's subtle, sort of gait imbalance, feeling less steady on their feet, tripping, slipping. In terms of the fine motor, I ask about difficulty with knots and buttons. You know, if they're dropping things, bladder changes in terms of their perception there, numbness, proprioceptive deficits. And then in the signs I would look for on physical exam include gait imbalance, and I try to increase my sensitivity by having people walk heel-toe, the sort of tandem gait. Looking for weakness, which I would say is usually a relatively late sign, hyperreflexia, including Hoffman's sign, deep tendon reflexes of the upper and lower extremities, looking for the Babinski response. I'll check vibration and or proprioception if I'm concerned about myelopathy. For me in my clinical practice is honestly a bit more of a sort of gestalt, and you know, probably like many physicians, there's some variability from the day to day in terms of how I approach it, and some variability based on, you know, the other patient specific factors. That said, the modified Japanese Orthopedic Association score is seems like a pretty good one in terms of classifying the severity of myelopathic symptoms. I would say, and then in terms of the imaging, I would certainly get a cervical MRI, or if that were contraindicated for some reason, then a CT myelography. Electrodiagnostics don't help you, or EMG nerve conduction studies at least don't really help you with cervical myelopathy, because it's an upper motor neuron lesion. So if the MRI shows severe severe canal stenosis, severe spinal canal stenosis with or without cord signal change, and there's a clinical picture like I described, I have a pretty low threshold to refer patients at least to speak with the surgeon and sort of learn what their options are, and put a face to a name and sort of know who they're going to call if they get worse. If people are clearly deteriorating or more symptomatic, then or if I had one patient who did have a recent onset of myelopathic and radiculopathic symptoms after a traumatic injury, and I referred her very quickly to surgery with a strong recommendation that she consider surgery, which she ended up getting. You know, many patients are more in that sort of gray area where you try, like the feelings paper, the reference number 5 talks about, you try to sort of educate people as to the potential risks and the benefits and the uncertainty, and the idea that surgery is largely arresting decline more so than fixing things, or at least in terms of like the purpose of it, and that it's not without risk. But I you know, I think depending on how risk averse people are or what needs they have to preserve their function and how clear the picture is, I have a pretty low threshold to refer to a surgeon if the patient does have cervical myelopathy, or at least if I think they do. For cervical radiculopathy, the Enquist papers, like I mentioned, and the Bono guideline, which is reference 20, both have fairly loose definitions of what cervical radiculopathy is. For me, in my own practice, I try to get the ducks in a row. In order for myself to call it a cervical radiculopathy, I like to see a pretty clear dermatomal pain pattern with at least some degree of correlating sensory and or motor signs. if the MRI shows a big disc herniation at the relevant nerve root level, then that's helpful. If there's sort of mild neuroforaminal stenosis everywhere, that doesn't help me as much. Or if there's, if the foramina are wide open, if there's clearly no impingement of the nerve root, that would steer me away, obviously. If it's sort of intermediate, then sometimes I'll order an EMG nerve conduction study to try to characterize that, or I suppose I would. I don't know that I've necessarily been in that situation, but certainly there's other entities that can cause arm pain. Shoulder glenohumeral pathology can radiate a little ways down the arm. Median mononeuropathy, ulnar mononeuropathy, brachial plexopathies can be mistaken clinically for cervical radiculopathy. So I don't think that an EMG is always required. I think an MRI once again is sort of mandatory, or a CT myelogram if the MRI is not an option. EMG I think kind of helps you in edge cases, but I wouldn't say that it's a must-have for the majority of patients, certainly. And then, so based on, we talked a little bit earlier about this sort of consensus that the natural history of radiculopathy is usually pretty favorable. And so within that understanding, the way I was trained to think about the indications for surgery are really that it's either intractable pain or a progressive neurologic deficit. So weakness is not necessarily an indication for surgery, but weakness that is worsening, I would say is. And what is intractable pain? To me, that's in the eye of the patient. I think again, there's a role for shared decision making and helping people understand that better days are usually ahead, and that there are options in terms of analgesic medications, whether that's NSAIDs. Sometimes for acute radiculopathies, I will prescribe opiates. I don't really do that otherwise, but because the natural history is favorable, if I have a patient who I think is a low risk of addiction and I just am trying to get them over the hump for those few weeks while the pain is really bad, I think opiates are a reasonable consideration. I think epidural steroid injections are a reasonable consideration. But if the pain isn't getting better with that non-operative care, or if the patient is just in so much agony and really, really wants to see a surgeon, or again, if they have a progressive neurologic deficit, those are all circumstances where I would refer to surgery. With regard to central spinal stenosis without radiculopathy or myelopathy, I wouldn't typically send those patients to a surgeon unless the patient really wanted to have the conversation, or I thought they were at unusually high risk of progression. I think, this one of the things highlighted in this literature review was that ossification of the posterior longitudinal ligament, which is a radiologic finding on CT or X-ray scan, is a worse prognostic factor in terms of the progression of asymptomatic cord compression to clinical myelopathy. In general, my training and my clinical practice agrees with the feelings kind of recommendations, which aren't particularly evidence-based, but almost more philosophical, which is that the risk of somebody developing myelopathy is a bit uncertain, and the risk of intervention is small but non-zero, and you don't really know whether somebody's going to progress or how fast they're going to progress. And so for that central spinal stenosis, again, I would tend to think that watchful waiting is best, but would certainly have the conversation with the patient and kind of try to engage them in that shared decision making. And if they really wanted to talk to a surgeon, I would facilitate the referral.
Okay, thank you very much, Dr. Shivers. I'm going to hand it over to Dr. Moynihan in just a moment here. Dr. Ratliff, I believe you might have had a question or comment about one of the questions. I'm sorry I didn't see it before. I apologize. We have a couple minutes if you would like to ask that or address that before we move on to the surgical questions.
Hi, this is John Ratliff, one of the spine surgeons from Stanford. Can you guys hear me okay?
Yes, we can.
Fantastic. Sorry about the trouble with the audio pin before. Glad I was able to get in. Just a couple of quick comments, and this is a great discussion. It's a very thorough review of the literature, and I think a very thoughtful approach to discussing these focused questions. With regards to smoking use, from the last question, I would hesitate to adopt that as a hard restriction with regards to coverage policy or anything that would incorporate into a LCD or NCD approach. We have patients with severe myelopathy, with severe core compression, who are smokers who simply can't quit. and where withholding surgery for their core compression based on their smoking would not be optimal treatment for the patient, although obviously smoking and nicotine use is likely an independent predictor of poor fusion and impaired surgical outcomes. With regards to the criteria for offering cervical fusion surgery that Dr. Shivers just did such a fantastic job of reviewing, I'd only offer that CT scan in conjunction with MRI, maybe not CT myelogram, but a CT scan in isolation, oftentimes will give us very useful clinical information with regards to surgical planning. We can see facet arthropathy and degrees of foraminal stenosis on a CT scanning that we may not see on an MRI, or a CT scan just gives us, or at least as I tell my patients, just another piece of the puzzle. It's another way to understand fully what's going on with the patient's spine, and I've certainly changed my operative strategy based on a CT scan in multiple patients, and not only in patients with OPLL, but also in some patients with just more basic cervical radiculopathy or more basic cervical pathologies. The only other note I'd make from question 5 would be the value of an EMG in patients with myelopathy. Certainly any spine surgeon will have surgically treated people with myelopathy who previously had a carpal tunnel release and previously had an ulnar nerve release, and finally they had imaging of their cervical spine, and they were found to have cervical stenosis, and they're referred for treatment of their primary condition, which is their core compression, their cervical spondylitic myelopathy. However, having an EMG and having an understanding in a myelopathic patient, if they have coincident carpal tunnel or coincident ulnar neuropathy, is extremely helpful. And it's extremely helpful for a global approach to the patient's symptom complex. And certainly those conditions are not an either or. Sometimes we'll be able to demonstrate the severity of a patient's myelopathy by ruling out a peripheral nerve compression or ruling out a entrapment neuropathy, which sometimes EMG can do. So while EMG, I think, is more helpful, more diagnostic, and more confirmatory in cervical radiculopathy patients, I still say in myelopathy it plays a role. And sometimes we will learn in our myelopathic patients important clinical information with an EMG. And thank you again for that great review. It's a good coverage of 2 very broad questions and a lot of content. Great job, Dr. Shivers.
Thank you for your kind words.
And thank you,
just
Dr.
to echo Dr. Ratliff on that, I would agree 100% with what he said about the non-contrast CT scan. That, as I think in terms of advising patients on whether to get surgery, that CT scan isn't necessarily that helpful for me as a non-surgeon, but I agree that the surgeons that I am aware of will routinely order CT scans, and you know, that is an important factor in terms of their operative planning, if not the binary of whether or not to operate.
Well, thank you both for your comments. I really appreciate it. I'm going to turn it back over to Dr. Moynihan.
Thank you. Before we get started on the surgical questions, Dr. Ratliff, because you had some issues with your audio pin, which I have often had myself, could you please just announce yourself and where your field of specialty is, where you practice, and whether you have any conflicts, because we need that for the record.
I'd be happy to, and apologies for the difficulty with the audio pin before. My name is John Ratliff. I'm a neurosurgeon specializing in spine surgery. My practice is probably over 90% spine, mostly adult and mostly degenerative, with both cervical and lumbar procedures and essentially the entirety of the spine. I practice at Stanford University. I had conflicts that I shared before, none of which are material to the discussion we're having today about cervical fusion.
Okay, then we are going to proceed to question number 7, because as I previously stated, we moved number 6 to the end of the discussion. Does anterior cervical decompression with fusion, ACDF, result in better outcomes, clinical or radiographic, than anterior cervical decompression, ACD, alone? Dr. Kellogg. Dr. Kellogg, are you having trouble unmuting?
Yes, thank you. This is Jordy Kellogg. The citations citation that was most relevant to this question was by Dr. Bono at Brigham, which was a summary of the NAS evidence-based guideline. And the study that was the strongest study answering this question was by Dr. Xie, XIE. Pardon the enunciation if I got that wrong. And that was a level 2 evidence that demonstrated that anterior cervical discectomy and anterior cervical discectomy fusion had similar clinical outcomes. And the second portion, or within the same question, is radiologically, is there a difference? And radiologically, the ACDF was found to have improved lordosis, where they're with a anterior cervical discectomy frequently developed a kyphosis. And what I found surprising in reading this was, or not so surprising, I guess, that the part of the desire, I suppose, for anterior cervical discectomy is preservation of motion, that 70% of them go on to fuse on their own anyway with a kyphotic deformity. And there's really no studies that I've found demonstrating changes as far as adjacent level disease with the ACD versus ACDF. Revisions were higher, but not part of this study. There were other studies that were weaker, level 3 studies. The two citations in Dr. Bono's paper were from Dr. Xie and Dr. Barlocker, which was a class level 3 study, and both of those demonstrated improvement in the lack of or not developing kyphosis with an ACDF versus an ACD. Thank you.
Thank you, Dr. Kellogg. Are there any questions from the panel members or comments or from the contractor medical directors? And please state your name before you speak. None? Okay.
Hey, it's John Ratliff. Sorry about that. I raised my hand. I don't guess this raising hand thing is working.
I'm not sure that I'm seeing it, but I'm relying on folks to tell me that somebody's hand's up.
Apologies
Go
for
ahead.
that. I just quickly say that there is some very over 20-year, 25-year-old papers looking at anterior cervical discectomy versus anterior cervical discectomy and fusion, and papers that note similar clinical outcomes in the anterior cervical discectomy group compared to an ACDF without an anterior cervical plate. Again, these papers are from over 20 years ago. Happy to share them if it would be of benefit for the CAC. It's definitely something from the history of medicine. What was seen in the anterior cervical discectomy alone group is that the patients would generally proceed to a fusion, but they proceed to a fusion in kyphosis, like developing a mild deformity at the site of the discectomy as the two vertebral bodies would collapse into each other and then proceed to arthrodese. We've learned the hard way that leaving patients in kyphosis clinically can produce suboptimal results, hence the interest in fusion technology and implants to decrease subsidence, to decrease the risk of kyphosis, and to maintain cervical alignment in this patient population.
Thank you. Any other comments? All right, then I'm going to move on to question 8. What is the evidence and/or society guidelines concerning the efficacy of cervical total disc arthroplasty disc replacement compared to anterior cervical decompression with fusion, ACDF? This is Dr. Slavin. And anybody who's not speaking, please go on mute. Are you having trouble unmuting, Dr. Slavin? Is he on at the moment?
Can you hear me? Hello?
There you go. You must have unmuted yourself. Thank you. Question 8.
Thank you very much for waiting for me. I apologize for the microphone issues. Can you hear me well now?
Yes.
Excellent, excellent. So the question was about the evidence or society guidelines concerning efficacy of cervical disc arthroplasty. I'm just reading from the screen right now. And I got to tell you that the cervical disc arthroplasty has been introduced about 20 years ago or so as essentially an alternative treatment for cervical disc degenerative diseases. With a mobile device between two vertebral bones, the mobility of operated segment can be preserved, and that may potentially decrease the incidence of adjacent segment disease. Moreover, the arthroplasty was reported to show better improvement in clinical functions compared to fusion surgery because of the normal kinematics of the involved segments. The numerous studies have compared clinical results and complications, but the conclusions, unfortunately, are not completely consistent, but nevertheless, they're very positive overall. So if you look at the references that were provided with this request, the reference 32, which is Dr. Munaneni's paper from 2012, was a summary of systematic review of 2 FDA trials that were reporting outcomes following cervical disc replacement with Bryan and Prestige discs versus anterior cervical discectomy and fusion in 4 and 5 years. They clearly established that arthroplasty is a viable treatment option for cervical herniated disc and spondylosis with radiculopathy, resulting in improved clinical outcomes, maintenance of normal segmental motion, and low rates of subsequent surgical procedures. Subsequent to that, there were several other papers, including paper by Dr. Heisey, which is mentioned here as reference 21, and 2 other papers by Dr. Jackson and Dr. Radcliffe. They were not included in the summary, but I'll be happy to send them if needed. And all of these papers analyzed 4, 5, and 7-year results of randomized prospective comparison of cervical arthroplasty with Mobi-C disc versus ACDF. And the papers were published in 2015, 16, and 17, respectively. They discovered that although both interventions, the cervical disc arthroplasty and cervical discectomy and fusion, result in significant improvement in neck disability index scores and pain measured by visual analog scores, the arthroplasty patients maintained motion and had significantly lower rates of reoperations and adjacent segment degeneration compared to ACDF. In addition to this, the last study from 2017 showed that 2-level arthroplasty demonstrated clinical superiority over anterior cervical discectomy and fusion, whereas single-level arthroplasty was non-inferior to ACDF. Of note, the 88% of patients with ACDF and more than 95% of patients with arthroplasty were, in quotes, very satisfied at 7 years after surgery. There was meta-analysis by Dr. Zhang, listed here as reference 24, which was published in BMC Neurology. And this meta-analysis summarized 13 randomized controlled trial studies with more than 60 months of follow-up. The pooled results indicated that cervical arthroplasty group exhibited significantly better outcomes in clinical scores, and preservation of range of motion than ACDF group. Meanwhile, the incidence of adjacent segment disease and occurrence of reoperation were lower in the arthroplasty group compared to ACDF. There was a recent paper by Dr. Zhang in Frontiers of Surgery, published in 2023. It's not included. I'll be happy to send it over. It's an open access. That reviewed 8 randomized controlled studies that focused on very specific cervical disc discover, and they show that both arthroplasty and ACDF have similar results in terms of neck disability index scores, pain scores, quality of life scores, and dysphagia. In addition, arthroplasty could reduce risk of adjacent segment disease, but increase risk of reoperation. Similarly, the 2023 systematic review and meta-analysis of randomized clinical trials with more than a minimum follow-up of 7 years, which is here listed as reference 23, compared cervical arthroplasty and anterior cervical arthrodesis. It was published by Dr. Nunez and colleagues, and they analyzed results of 2,664 patients, found significant improvements in both groups with higher motion rate, higher overall success rate, higher improvement in neck disability index, and less VAS arm pain in arthroplasty patients compared to ACDF. There was no significant difference in neck pain scale or adverse events. And finally, the 2021 randomized clinical trial, which is here under reference 22, by Dr. Johansen in Norway, that was published in JAMA, compared a total of 136 patients with 5 years follow-up in 84%. The authors concluded that patients treated with arthroplasty and fusion have similar and substantial clinical improvements in 5 years. So in preparation for today's conversation, I looked at the guidelines from the societies, and I didn't see any specific mention of arthroplasty versus cervical discectomy and fusion as a treatment option, but there's plenty of recommendations for anterior approach for treatment of a variety of cervical pathology, and I think we'll talk briefly about this later when we discuss cervical myelopathy. So I believe there's plenty of evidence to suggest that both of these modalities are effective. There's some controversy which one is effective in terms of one parameter or the other, but they're definitely non-inferior to each other, and the cervical disc replacement for specific indications in very specific patient cohorts is definitely a valid option, which is on par with discectomy and fusion. That's it for this one.
Thank you. Are there any comments or questions from the CMDs or panelists?
This is Dr. Train Ellis from Rush. It was an excellent review. I just want to make 2 comments. The first is, if we look at the data at 2 year, there's not much difference. And really the break point comes at 5 to 7 years, where arthroplasty pulls ahead in terms of the need for less surgery. The second is, it looks good, but all patients do not qualify for arthroplasty. This is a subset of patients that need anterior decompressions. It's a select subset, so we can't generalize arthroplasty to all patients presenting and with anterior pathology.
These are wonderful comments. Thank you very much, Dr. Tranellis. I mean, I don't think anybody on this call has as much expertise as you in this area. So I fully agree with you, and I think it makes perfect sense.
Okay, thank you. Moving on to question number 9. What are the indications for single versus multi-level fusion, and what are the limitations for the number of levels fused? Dr. Tranellis?
Well, let me start by saying that the indications for single versus multi-levels are a little bit based on the pathology. It is possible but unusual to have 3 levels of disc herniation causing radiculopathy. This is usually a 1 or 2 level problem, whereas with myelopathy, in the setting of congenital stenosis, is more frequently a multi-level disease. So the type of pathology being treated will impact the number of levels in which surgery is required. If we look at the anterior data and now focus on myelopathy, because these are patients that are going to have multiple levels, there is a trend of surgeons to limit the number of levels they do anteriorly, a number of studies, to maybe 3. And if patients required more than 3 levels, they chose a posterior approach. And the reason was twofold. One is concern for dysphagia. The dysphagia data, and it's listed, it was touched upon with complications, is really a little muggy, because when we look at studies of anterior surgery and dysphagia rates postoperatively, no study details how many patients had dysphagia prior to surgery, and almost no study uses a validated measure of dysphagia. It's simply a question, how do you swallow? So we don't really know what is the actual rate. There's no question there is some problem early on. How serious, how long it lasts is not fully defined. The other is fusion rate, though. From the articles supplied in the review, as well as multiple other articles, it is clear that the more levels addressed anteriorly, the lower the fusion rate. In fact, 4 and 5 level anterior surgeries probably, if we're honest, have a fusion rate of 50%. And so this is another concern with the anterior approach. If we look posteriorly, certainly it is mostly a multi-level disease that requires a fusion. There is a historical body of literature of laminectomy alone, and probably at least a 20% kyphosis rate. Post-laminectomy membrane syndrome is probably a sign of some sort of subtle instability, and all of these things can be eliminated with a fusion. So multi-level posterior cases will frequently require fusion. Not listed here was a posterior strategy laminoplasty. It's a non-fusion strategy, and it is very beneficial in select patients. These patients cannot have instability. They cannot have a number of factors, including facet arthropathy. But in select patients, it is an excellent treatment, just as arthroplasty, a non-fusion technology for anterior surgery, is an excellent strategy. And so the considerations are how many levels, and whether the pathology is anterior or posterior. OPLL, primarily anterior pathology, can be treated with posterior decompression if the OPLL is not extending into the center of the spinal canal. But most other degenerative anterior pathologies, or at least many of them, if there is significant anterior cord compression, would require an anterior approach. And finally, not mentioned in here, there are combined strategies where an individual may get a 1 or 2 level anterior decompression, and then this is for myelopathy, and then in a delayed fashion, if improvement is not noted and there's persistent dorsal compression, a dorsal procedure. And as I see it, these are the factors, and so one approach is not superior to others. It will depend on the patient presentation and also some surgeon experience in terms of what they have to offer.
Thank you, Dr. Charnelis. Are there any comments or questions from the CMDs or panel members? Okay. Moving on to question 10. What are the considerations for determining surgical approach, anterior, posterior, or combined? Does evidence support one surgical approach is superior to others? If so, what evidence? I think we heard a little bit about this, but I don't know if you want to comment further, Dr. Relic.
Yes, I'd like to make a few comments on this. I think dovetail very well with the comments Dr. Charnelis just made. I would say just at the outset, there's not a one-size-fits-all approach to cervical degenerative disc disease and to the variety of pathologies in the cervical spine. So there's not answering the question really evidence that there's one approach that's superior to every other approach in every patient. Each of these clinical decisions has to be predicated and based on the pattern of cervical degenerative disease and the pattern of pathology in a given patient. As Dr. Charnelis pointed out, for 1 and 2 level disease or 1 and 2 motion segments of cervical stenosis, cervical degenerative changes, surgical bias is usually towards an anterior approach because we classically see fewer complications and a quicker recovery with less pain utilizing an anterior approach. As you get to 3 levels of disease, you see the fusion rate drop off. You do not have any 3-level cervical arthroplasty procedures that are FDA approved, and you start worrying about your approach-related complications with an anterior approach. In patients with kyphosis, though, meaning a cervical deformity, sometimes a multi-level anterior approach is necessary. And in that subset of patients, you may choose to do a combined approach, meaning both an anterior and a posterior stabilization out of fear of a pseudoarthrosis or a failure of your fusion, or if you're to do a corpectomy or a more extensive anterior decompression, fear of dislodgement or migration of your corpectomy reconstructive strut graft or reconstructive cage. So looking through the articles, there's some very good literature that's reviewed in the bibliography. Probably one of the most interesting is, I think, citation 33 from the bibliography, which is Zogoguala's study from JAMA published in 2021. He randomized patients with cervical spondylitic myelopathy who could be treated either ventrally or dorsally, meaning either an anterior approach or a posterior approach, where he actually had surgeons review the studies, make sure the patient was a good candidate for either an anterior approach or a posterior approach. And he found in that study essentially no difference in overall outcomes. Clinical recovery in the patients were comparable between either an anterior approach or a posterior approach. Now, that's in a subset of patients who could be treated anteriorly. So the most were, I believe, 2 and 3 level surgeries. He did see a higher number of complications with the anterior approach, with the most common complication being dysphagia. And here you run into the same issue that Dr. Trinellis pointed out, that quantifying dysphagia is difficult, and essentially everyone having an anterior approach to the cervical spine will have some degree of dysphagia in the early postoperative setting. That may not have meaningful clinical impact, though. Satari's article, which is, I think, citation number 31, was a meta-analysis looking at multiple studies, and again, trying to compare anterior and posterior approaches. Here again, the number of procedures were relatively low, around an average level of 3 segments being fused. In this meta-analysis, he managed to find 19 studies with over 8,000 patients and a pretty even split between anterior cervical approaches and posterior cervical approaches. His meta-analysis showed the clinical results were essentially similar. Both groups of patients had improvement with comparable outcomes. His conclusion was, quote, "The authors recommend individualized treatment decision-making," close quote. A similar recommendation was made by Lee's study, which is citation 30, another meta-analysis, and then the spine section's recommendations, which are summarized in Dr. Hadley's articles from neurosurgery from 2002, looking at spinal fractures, which I know we'll get to in a later question. Again, notes that the operative technique depends on the patient pathology. So a long-winded answer to the question, I don't think there's a one-size-fits-all approach, and either anterior approaches, posterior approaches, or combined approaches can have good clinical outcomes, and the surgical approach needs to be tailored to the individual patient's pathology.
Thank you. Does anyone from the panel have any more comments or questions, and or the CMDs comments or questions? Okay, then I'm going to move on to question 11. What is the anticipated relief period following a cervical fusion, and how often are surgical revisions necessary? Dr. Kellogg?
Yes, thank you, Jordy Kellogg. The citation, again, was Dr. Bono's paper from the NAS guidelines, and the study that was in the guidelines was rated as a C. It was at level 3. It was a Dr. Worth study, and it was 60 months follow-up. That surgical or ACDF did provide long-term treatment. 2 other articles that were added on. One is a Swedish study that had, from a randomized trial that they performed, a 20-year phone follow-up, which had similar results of 88% favorable outcomes. I would say that most of us that do a fusion, once they're fused, that segment is static and doesn't become a problem in the future. It's the adjacent level that becomes a problem. Regarding revision, the paper by Dr. Buyuk, B-U-Y-U-K, in the Journal of Spine Surgery, looked at revision for pseudoarthrosis. Of course, there could be revision for a number of things, but in this paper, it was for pseudoarthrosis, and it was comparing using a peak cage versus a Cloward technique. And what they found was results of pseudoarthrosis requiring revision of 8% for the allograft patients and 14% for the peak patients. And in preparing for today, it was interesting to me that many studies, just because there's a pseudoarthrosis doesn't necessarily mean they're overly symptomatic or require a revision. Not necessarily that's how I do my practice, but it is an interesting thought for me to consider. And so that's what the 3 papers that were cited. That's what I got out of that. 8 to 14% need for revision for pseudoarthrosis. Thank you.
Are there other comments or questions from panel members or CMDs?
This is Vincent Jornelis from Chicago. I just want to make a general comment on the Bono paper. This is a paper looking at the diagnosis and treatment of cervical radiculopathy. So this is focused not on myelopathy, but radiculopathy. And we should keep that in mind, because I would suspect at least half, if not more, of the Medicare population are going to be treated for myelopathy. So I just want to make that point.
Thank you. Are there any other comments? Okay, then we are going to move on to question 12, which I think has been partially or somewhat covered before. What surgical techniques are best for cervical spondylotic myelopathy, Dr. Slavin?
Thank you very much. And yes, you're right. I would like to thank Dr. Ratley for covering most of my answer for this question. But he did remarkably well. And if you don't mind, I'll just briefly explain what's going on, what myelopathy is, and what we're trying to treat. So in general, the myelopathy, cervical spondylotic myelopathy, is the most common cause of spinal cord dysfunction worldwide. It presents insidiously with clinical symptoms, which could be gait instability, bladder dysfunction, fine finger motor difficulties, as well as objective signs such as hyperreflexia, weakness.
Excuse me, doctor. Could everybody who's not speaking please mute? It's hard to hear him. Go ahead, doctor.
Thank you very much. Yes, you're right. It's much nicer now. So the cervical myelopathy has both symptoms and signs could be hyperreflexia, weakness, alteration of proprioception, affecting both motor sensory pathways. So neurological dysfunction results from essentially dynamic repeated spinal cord compression from cervical spine degenerative arthritis, resulting in axonal stretch injury and spinal cord ischemia. The surgery to decompress spinal cord, usually with fusion, is frequently performed for severe or progressive symptoms, and the optimal surgical approach for cervical myelopathy essentially remains unknown. Clinical equipoise exists for randomized studies. In the United States surgical practice, both ventral and dorsal decompression and fusion dominate. In laminoplasty, which was briefly mentioned earlier, remains done at a lesser extent. So back in 2009, the Institute of Medicine designated cervical myelopathy as one of the top 100 national health priorities for comparative effectiveness research because of this severity and importance. The ventral fusion surgery, the surgery from the front, has been associated with significantly better health-related quality of life and less neck pain. And some inpatient databases showed a lower 5-year adjusted reoperation rate for ventral fusion compared to dorsal fusions. But in general, the answer is still open. As a matter of fact, there are some published guidelines from AO Spine North America and Cervical Spine Research Society that came out in 2017 in Global Spine Journal by Dr. Fellings and colleagues. There's also a guideline from World Federation of Neurosurgical Society as well as Italian Society of Neurosurgery in Neurospine this year by Costa and colleagues. And there's Japanese Orthopedic Association guidelines by Dr. Watanabe and colleagues in 2023, published in Journal of Orthopedic Sciences. All of them recognize value of both anterior and posterior surgical interventions in patients with cervical spondylitic myelopathy. But they do not answer the question which one is better. So in the United States, the Journal of Neurosurgery Spine in 2009 published a series of papers covering each of these procedures separately. There was a paper on cervical laminectomy without fusion. There was a paper on cervical laminoplasty, cervical laminectomy with fusion, as well as anterior cervical discectomy and fusion on multiple levels. The summarizing paper by Dr. Munaneni analyzed different surgical techniques for treatment of cervical spondylitic myelopathy specifically. And the overall conclusion was that multiple existing approaches result in similar near-term improvements, but laminectomy, which is decompression without fusion, appears to have late deterioration rate that may need to be considered when appropriate. The meta-analysis by Montana that was published in World Neurosurgery in 2019, I'll be happy to provide it, suggested that ACDF should be preferred to laminoplasty for treatment of multi-level cervical myelopathy, but they noticed that there were no properly designed randomized controlled trials. So in order to determine whether ventral surgical approach compared to dorsal surgical approach for treatment of myelopathy improved patient-reported physical functioning at the year, there was study that was already mentioned by Dr. Ratliff. It was cervical spondylitic myelopathy surgical trial, CSMS, that was put together in multi-center format. There were 15 centers in North America, 14 in the US, 1 in Canada, with patients enrolled between 2014 and 18. And the 2-year data collection was completed in 2020, and the paper was published in JAMA in 2021. That's reference 33. With 458 patients screened, there were 269 enrolled and 163 were randomized. And they were randomized to 3 different options. And the author discovered that both ventral surgery with anterior cervical disc removal and dorsal surgery with laminectomy and instrumented fusion or open door laminoplasty resulted in significant improvements in both physical component of short-term SF36, physical component summary score improved by 5 to 10 points at 1 and 2 years, and that was their primary outcome. The neck disability index scores improved by 10 to 17 points at 1 year and 12 to 16 points at 2 years with all these interventions. That was their secondary outcome. And there was no significant differences between ventral and dorsal surgery. Finally, the most recent meta-analysis by Dr. Satari and colleagues that was published in 2023 is here as reference 31, which was also mentioned by Dr. Ratliff, was focused specifically on comparison between anterior cervical discectomy and fusion versus posterior decompression. It included 19 studies and comprised of 8,340 patients. It found that anterior cervical discectomy and fusion and posterior decompression were similar regarding functional outcomes. They both were very beneficial in terms of improvement by all available indicators. The anterior cervical discectomy and fusion was beneficial in terms of less bleeding, shorter lengths of stay, and lower odds of surgical site infection and C5 palsy, while at the same time it carried higher odds of dysphagia. This prompted the authors to recommend individualized treatment decision making. So I guess to briefly answer which surgical techniques are best, I think what has already been mentioned previously makes sense. It should be individually tailored based on patient's anatomy and radiographic findings. And the combination of MRI and CT seems to be the best guide in terms of choice of intervention, because whenever it comes to kyphotic deformity, which may need to be addressed from ventral procedure, or certain interventions that really need to be done in combined approach with both anterior and posterior stabilization. Those things have to be decided individually. The only thing there's full consensus, yeah, that surgery definitely improves the patient's disability, their functioning and quality of life, as well as their pain levels. Thank you.
Thank you, Doctor. Are there any comments or questions from CMDs or panelists? Hearing none, move on to question 13. Does ACDF with instrumentation result in better outcomes, clinical or radiographic, than ACDF without instrumentation? Dr. Trinellis.
If we start with reference 20, which is the Bono paper, it was their conclusion that both ACDF with and without a plate were comparable, producing similar clinical outcomes and fusion rates in the treatment of single level cervical radiculopathy. They also stated that the addition of a plate was suggested to improve sagittal alignment, and the graded recommendation for both of these was a B. The conclusion was that although it may be indicated in some patients undergoing multi-level ACDF, there's insufficient evidence that practice results in significant improvement in clinical outcomes. So it's a little bit mixed in this paper in that with a single level, they don't see any difference, and they don't present much data with the multi-level. And the plate, there's a strong body of literature dating back decades when plates first came out, debating this very issue. And it is clear, especially with a single level, the addition of a plate does not add a great deal. It does improve fusion rate with allograft. And if there's a two-level fusion, then the fusion results unplated with autograft, iliac crest autograft versus allograft are significantly different. The addition of the plate brought the fusion rates in line. So the plate allows us to perform multi-level fusions without subjecting the patient to harvesting their own iliac crest, which has its own moderately high short-term morbidity. And so the plate does improve fusion rates. We can debate whether fusion improves clinical outcome overall, but I would subject one to the position that if part of the procedure is to perform a fusion, then all should be done possible to make that fusion successful. Not touched upon in this question, but a related question is the standalone. So standalone devices are simply interbody devices fixated to the adjoining vertebral bodies with screws, but there's no plate. There's robust literature that shows the dysphagia rate with the standalone is less than that with the plate. So even though the plates are only 2 to 3 millimeters in thickness, it's enough that will increase overall dysphagia rates. The price of lowering dysphagia rates with an inner body, though, is subsidence. These devices are much more prone to subside and produce some kyphosis. The fusion rates between the two are similar. And so it is another type of instrumented anterior fusion, although not specifically with a plate. So in summary, today, most patients are treated with allograft, or they use inert spacers with a variety of bone products that promote bone growth and fusion. And the plate, clearly, at least with the allograft, improves our fusion rates when it's more than one level, and decreases subsidence rates as well if it's more than one level. And that's has led to the adoption of plating these anterior cases. And that's my report.
Thank you. Are there comments or questions from the CMDs or the panelists? All right, I'm going to move on to questions.
Dr. Slager, I just want to make sure that people understand that this question about using instrumentation during anterior cervical fusion was much more relevant in the past when people did not use plates routinely. These days, this is rarely done. I haven't heard of cervical fusion done without plate. The standalone devices Dr. Trinelis referred to, they have integrated plate and cage and some screws put through this. But back in the day, during Clower's time, when these fusions were done without plates, that was a very relevant thing. These days, I don't think it's relevant anymore. Just my 2 cents.
Vince Trinelis, I completely agree. A plated anterior case should be, I think it's considered the standard of care.
Okay, thank you for that additional information. I'd like to move on to question 14. Some of this has been covered before too. Are there materials or methods that are superior to others, such as corpectomy versus discectomy, types of materials, use of plates, etc.? Is there evidence to support a role for artificial disc? Dr. Ratliff.
Thank you. I think I can be much more succinct with this answer. For the artificial disc, I think we've actually already discussed that. Multiple commenters have already spoken to the studies outlining artificial disc. I'd only say, adding on to the comments that have previously been made on total disc arthroplasty, that the key there is really patient selection and making sure that the patient is an optimal candidate for a total disc arthroplasty. The studies in that space are generally of relatively young patients. The summary that Dr. Mumanini has is one of the citations from 2012, has a very young patient population with an average age of 44 years. So perhaps not relevant to Medicare beneficiaries that will be affected by the LCDs and NCDs that come out of this discussion. We've also discussed at length the difference between corpectomy versus multi-level discectomies, and Dr. Trinelis just spoke to anterior cervical plating, so not a lot that I need to add there. I'd only offer like 2 additional articles. One is, I think, citation 31 from your guys' bibliography. I'm sorry, the citation 28 from your guys' bibliography. Hermansen's article published in 2023. It's a really interesting article, and it has 20-year follow-up in a small group of patients undergoing anterior cervical discectomy with 2 different techniques. Either the Cloward technique that was mentioned, which is again kind of a history of medicine technique utilizing a bone graft harvested via a circular reaming device from the iliac crest, versus a more classic Smith-Robinson, which is, I think, a surgical technique that's probably more commonly used today than it was 20 years ago. And here, autograft, meaning harvest from the patient's iliac crest, versus a carbon fiber cage via a Smith-Robinson technique are compared. It's a very small patient population, but they showed good clinical outcomes and essentially no clinical difference between the 2 techniques. I don't know that there is literature support, certainly not from the bibliography, that would support one technique over another for anterior cervical discectomies and fusions. It's very hard to find recent literature reviewing uninstrumented anterior cervical approaches. And because, as Dr. Slavin and Dr. Trinelis have pointed out, the standard of care and kind of standard operating procedures for spine surgeons have really migrated towards utilizing routine anterior cervical fixation when doing anterior cervical reconstructions. I did find an article when I was looking around last night, which I can share. It is one where I would have to pull off the PDF. It's not an open access article, but it's from India, published in the journal Neurosurgery in 2002, Dr. Raj Shekhar. And again, I can share this if desired. But in this paper, they looked at around 90 patients undergoing cervical corpectomies, either 1 or 2 level corpectomy. So not just a discectomy, but an actual cervical corpectomy, where they did those in an uninstrumented fashion, meaning they didn't augment that anterior cervical reconstruction with an anterior cervical plate. And the study shows and kind of illustrates why I believe U.S. spine surgeons have migrated towards anterior plate fixation. And that's because the rate of kyphosis, or development of an abnormal, or what most surgeons would consider a pathologic spinal alignment was approximately 35% in these patients, meaning the loss of cervical lordosis and the development of a cervical malalignment was very common in these uninstrumented cervical corpectomies. And I think that fits in with the rationale or the reasoning behind the spine surgery community moving towards routinely using anterior cervical fixation in this space. And I'll stop there. I know we have like a big question 6 to tackle next.
Are there any comments or questions from the CMDs or other panelists? Okay. Thank you all for those answers and for moving us along. We are 2 hours into this call, and it is scheduled for another hour. Not that I want you to take that time. I'm going to turn this over to Dr. Summers to begin question 6, which is sort of our lightning round. Dr. Summers?
Yes, thank you. And thank you to our wonderful panelists, the experts today, who've really done an excellent job, I think, in summarizing the literature in this area. Question 6 has a number of subparts, as you see there. I'm going to handle the first 3, A, B, and C, and then Dr. Moynihan will bring it home with D and E. Question 6 reads, is there evidence to support the efficacy and safety of cervical fusion surgery compared to non-fusion surgical procedures and or conservative management for the following patients? Starting with subsection A, the patient with unstable spine, cervical instability in the context of a cervical spine fracture or dislocation, trauma or spinal cord injuries, or traumatic spondylolisthesis. And this is open to all the panelists. If you don't mind, please opine about on this topic, and then we'll move on to the other segments. Thank you. Anyone can start.
Ms. Trainellis, I could start. In terms of, in subgroup A, you mentioned instability. So there are spine fractures, cervical spinal fractures that are not unstable or that are so unstable they could be managed just with an orthosis. And we all recognize what those are and treat them non-operatively. If there is true instability in the presence of a fracture, dislocation, injury, any of these things, and spondylolisthesis, then is unequivocally a candidate. This patient is candidate for trauma, for surgery, and how the surgery is performed, excuse me, would be based on the pathology, where the fracture is, where the dislocation is. There's clear evidence that in the presence of spinal cord injury and compression of the spinal cord, that decompressing the cord is of value, and decompressing the cord as rapidly as possible is of value. And these procedures invariably then require fusion because there is injury. The decompression creates more instability, and so these are combined with fusions. I'll just start with those comments.
I would echo those comments to John Ratliff from Stanford. I think for cervical instability, I mean, the definition of instability is a lack or the inability of the spine to serve to protect the spinal cord and to protect vital neural elements. That has become, in the majority of patients, a clear indication for surgical stabilization and surgical reconstruction, surgical stabilization of that unstable fracture. Now, there are subsets of patients where utilization of a halo or utilization of a rigid external orthosis may be considered. There are patients where I'm sure each of the surgeons on this call maybe have started out utilizing a halo and then had to transition to a cervical fixation or to a cervical fusion surgery. So there's considerable heterogeneity in patients presenting with cervical fractures, both in regards to the bony morphology of the fracture but also the presenting neurologic exam. Whereas Dr. Tonellis notes, like patients presenting with a cervical spinal cord injury and focal cord compression are generally going to be of a much higher acuity and much greater need for timely operative intervention. Although sometimes we'll see patients with isolated facet fractures and more limited, but still unstable, potentially injuries who present with a severe radiculopathy or a pattern of motor deficit where the facet fracture is producing foraminal compromise, each of which may mandate operative intervention. Central cord syndromes, which are another population of patients, so we haven't really discussed here, are also a pathologic condition relatively common in patients of a Medicare beneficiary age where surgical therapy and cervical fusion surgery is quite often considered standard of care and quite often utilized.
Any other comments regarding unstable spine or cervical instability from the panelists or the CMDs or anyone else? Hearing none. Any comments about this question with respect to cervical radiculopathy?
I think the Bono paper does address it, and we've discussed it in the context of all these other subgroups previously. Not all radiculopathy requires a fusion. Some patients are candidates for arthroplasty, and a lateral soft disc herniation could be removed from a posterior approach without a fusion. But many of these patients have a bony osteophytes anteriorly and anterior pathology in addition to their radiculopathy, and they will require anterior fusion.
I would agree. I think John Ratliff from Sanford, I think we have kind of discussed radiculopathy and the variety of different operative treatments relevant to radiculopathy, where fusion's a routine tool and kind of the toolbox that spine surgeons use for cervical radiculopathies recalcitrant to conservative treatment.
Yes, okay, excellent, thank you. Subpart C deals with cervical myelopathy in the context of spondylolytic myelopathy, cervical myeloradiculopathy with sort of a mixed picture, and then mild myelopathic symptoms and signs. We may have covered some of that as well previously, but any other comments about under this subsection C?
Just I don't know that this is germane to the writing of the policy, but it kind of in with the myelopathy and in with the central spinal stenosis, we've been talking about all these situations, like the diagnosis is sort of clear, and I think there are a lot of instances clinically where somebody's walking a little bit funny and maybe their reflexes are a little bit brisker than you expect them to be, but the imaging isn't totally impressive and you're wondering if something else is going on. And there are certainly other neurological conditions that can cause deteriorations that could be mistaken for or could overlap with myelopathy. And so I think that it's, incumbent on all of us to make that diagnosis. But, you can't do, testing for Parkinson's disease in everybody, and you can't do an EMG to rule out ALS in everybody. It's more just sort of a side note comment on, the importance of the clinical and radiographic picture sort of fitting the diagnostic impression.
Dr. Shivers, is that you speaking?
Oh yes, I apologize. That was Shivers.
Okay, thanks.
All right, if there are no other comments or questions, I'm going to turn it over to Dr. Moynihan for the final section.
All right, we're on central spinal stenosis. Are there comments about central spinal stenosis in the same question?
Vince Trinellis from Rush. So central stenosis in the absence of myelopathic symptoms or signs is a topic of interest in our literature. There are fairly clear evidence that surgery is not indicated in these patients. The risk of catastrophic deterioration is very small. And when compared to maybe the risk of surgical complication, the margin is more narrow. So these patients, if they have severe stenosis, do concern us, and there may be times that SEP testing may help us if there's electrophysiological posterior cord dysfunction, despite our exam being normal, may push us to act. But in general, if we took all comers with central stenosis and essentially no symptoms, these people are not usually surgical candidates.
John Ratliff from Stanford. The only pushback I would offer on that is that all of these patients are getting imaged for some reason, meaning that we're not doing MRI screenings for people. So generally people are having some kind of complaint or some kind of problem that's leading to them undergoing cervical imaging, either cervical MRI, CT, or some advanced imaging that's producing the radiographic diagnosis of central spinal stenosis. And then the key becomes a thorough neurologic exam and assessment. And then in my own population of patients, really following these people over time. I agree completely with Dr. Trinellis is saying that these patients with minimally symptomatic central spinal stenosis generally can be safely followed. But I would hesitate to try to set up in an NCD or LCD what clinical findings warrant operative intervention in that subset of patients. I have patients who may develop C7 patterns of motor deficit and they won't even notice it because it's just not that big a deal to not be able to push away with your triceps unless you're doing push-ups or physically active or doing other demanding physical activities. Where a C8 pattern of deficit, where you start developing even mild weakness in your hand intrinsics for artists, for craftsmen, for people that are working with their hands or doing any kind of fine motor tasks, a mild pattern of deficit can be functionally very limiting. So even early findings of myelopathy in this subset of patients in specific patients may be indications for intervention. And again, it's something where the heterogeneity of presentation of these patients is going to make it difficult to mandate a coverage determination that will cover all of them, where you have to a certain degree, trust the patients and allow the treating physicians to help guide the different treatment options that are available.
Thank you. Any other comments?
Yes, this is Shivers again. I think that was really well said by both Dr. Trinellis and by Dr. Ratliff. You know, I think a common theme of the discussion today has been that for a lot of these situations, especially in terms of the surgical planning, there just isn't a one-size-fits-all answer, and that there's a lot of heterogeneity and clinical judgment required. And I really agree with that as a non-surgeon, I agree that, you know, in terms of figuring out the best operative approach, that's something a question I, you know, can, you know, opine on, but certainly end up yielding to the surgeon. I think this central spinal stenosis question is interesting and germane, and I agree. I think that trying to like write in a bunch of guidelines around it has the potential to be cumbersome. I also think that in terms of unscrupulous people kind of like slipping things in, that this is a big sort of gray area in that regard, insofar as some degree of central spinal stenosis is extremely common. And so we've been talking about it as though it is, you know, frank cord compression without symptoms, but radiologists will often call mild to moderate spinal stenosis just out of the sort of compulsive way that, you know, we're all supposed to comment on these things when we're looking at the radiology reports. So then you can end up in a situation where somebody got the MRI because they have severe axial cervical pain, and, you know, whoever was ordering the MRI was, you know, looking to rule out a tumor or just not necessarily following the guidelines in terms of imaging. And certainly I will order MRIs on patients with intractable axial pain just to sort of clear the board in that regard. But I think that there is some nuance to directing patients and kind of potentially having conversations with surgeons or reviewing the documentation to understand that the purpose of a potential surgery in that case is really to arrest or reverse neurologic decline, and not as an excuse to do a multi-level fusion on somebody who has axial pain and otherwise, based on their symptoms and signs, wouldn't qualify for the fusion surgery. And I say that with the utmost respect to everybody on the call, certainly in terms of all of the discussion and judgment here. But I do think that is a case where I sometimes see people who are operated on for pain of the neck, then you know, it's unfortunate. I don't know that it's the job of Medicare to police that, but I think that it's something to sort of be aware of, at least.
Thank you. Other comments? Hearing none, I'll move on to the final category, others, such as ankylosing spondylitis, diffuse idiopathic skeletal hyperestosis, malignancy, and tumors. Same question.
I guess this is more of a John Ray of Stanford. So for a traumatic patient with either dish or ankylosing spondylitis, those are patients that most commonly are going to be routed towards stabilization or fusion procedures. Ankylosing spondylitis as a diagnosis in isolation, meaning a non-traumatic AS patient, like they're fusing their spine already, not necessarily an indication for surgery, but when those patients will be presenting, it's generally going to be a Medicare beneficiary who's been involved in a motor vehicle accident or a fall with a head strike, who's going to have a fracture on top of their dish or on top of their ankylosing spondylitis. Dish meaning the diffuse idiopathic skeletal hyperestosis. So all of those patients are going to be routed towards operative intervention and generally operative stabilization.
Excuse me, doctor. Could you please mute your line if you're not speaking? Please mute your line if you're not speaking. Go ahead, doctor. Sorry.
No, quite all right. And the final question was the one about malignancies and tumors. For malignancies where there's a structural deformation or structural destruction of a highly mobile spinal element, such as the cervical spine, generally that is something where operative intervention is going to prove necessary. There are certainly cases like isolated plasmacytomas or multiple myeloma involving the spine, where radiation may be functional and radiation may be all that you need, but it's quite common that we see patients with pathologic fractures and vertebral body involvement from neoplasms where surgical reconstruction is necessary. For spinal cord tumors, for tumors intrinsic to the neural elements in the cervical spine, the risk of kyphosis or development of a worsening cervical alignment in surgical treatment of those patients is quite high. So it's also quite common that an arthrodesis or a stabilization procedure be incorporated when patients are presenting with an intramedullary, meaning an inside their spinal cord neoplasm necessitating operative treatment. So in each of these cases, an arthrodesis or a stabilization procedure is relatively commonly used.
Vince Trinellis from Rush. I agree. I think if you look at ankylosing spondylitis and DISH, those patients requiring cervical fusion are all going to be in the trauma category. If these entities cause a deformity, usually the correction may be done more caudal, at the cervical thoracic junction or thoracic spine, depending on where it is. It's less likely to be in the subaxial cervical spine. So these are trauma patients that have highly unstable fractures and would require fusion. Another subset of the tumor would be large neurofibromas and schwannomas. If removal of the tumor requires complete facet resection, then that creates instability. And so although these are benign tumors that may not require radiation, depending on the bony exposure required to safely remove them, fusion could be indicated.
This is Shivers from Pittsburgh again. I would just nominate to solicit opinions from the one or more of the surgeons on the call about the role of fusion surgery in infection as well, osteomyelitis, epidural abscess, those sorts of entities.
That's a great question, Ratliff from Stanford, of a set of patients that we haven't covered. The way the spine heals from a discitis is by fusion. So if you have, say, a discitis develop at your C5, C6 disc space, and generally that disc is going to be completely consumed by the infectious process, and then you'll have the spine heal via arthrodesis across the involved segment. So your end result here is a fusion, but without cervical stabilization and without surgical treatment, you certainly worry about epidural abscess, you worry about catastrophic neurologic compromise, you really worry about these patients deteriorating and perhaps deteriorating in a very dramatic fashion. So quite often these patients are treated surgically, and your surgical strategy usually involves both debridement of the involved infected bone, treatment of the patient's osteomyelitis with debridement of the involved vertebral bodies, and then reconstruction of the spine, be either bone graft or by use of titanium cages to restore structural alignment. And a lot of the times, in my hands at least, those patients are treated with both anterior and posterior approaches because of the severity of the bony destruction and the severity of pathology in infection patients who end up needing surgical treatment. Now, you can also have patients that you can treat successfully with antibiotics, and purely medically, if you, in my clinical experience at least, pick up the infection very early in its course and begin an aggressive course of IV antibiotics before the patient goes ahead to develop a severe destruction of the disc or epidural abscess or other evidence of worsening structural deformity of their spine.
Any other comments? Okay, I think that concludes our questions at this point. So we'd like to thank the CAC panel for this information and the discussions, and for taking time out of your day to be here and share your expertise. We'd like to thank all those who are listening, and also the other CMDs. The MAC CMDs will take the information from today's meeting and continue discussions on the topic. Please monitor the MAC websites and listservs where the publishing of a proposed LCD for public comment will be communicated once it's done. We thank you all again for your time today. I would like to say that we do need to have articles that you referred to that were not on the list sent in, and anyone who has written comments, please be sure to send them in. And other than that, have a wonderful day. Stay safe, and you finished ahead of time in a project I never thought you would. Thanks again.
Not to belabor things, but who should we send the articles to, or who's the point of contact for any citations that we discussed on the call?
Yeah, Carrie, did you say that in the beginning of where they send?
Dr. Moynihan, this is Jocelyn. Yeah. You can email them to cacmeeting@noridian.com.
Did you get that? Want to repeat it one more time, Jocelyn?
Email is cacmeeting@noridian.com. So it's CACMEETING @noridian.com.
Thank you. Thanks, everybody.